So this afternoon we'll be hearing about lessons learned from an AI-enabled diabetic retinopathy screening at San Ysidro Health. And I will hand it over to our speaker, Sonia and Edgar. Thank you so much for joining us.
Thank you so much, Sierra. Thank you, CCI team, for inviting us. We're going to try to do our best to kind of share with you guys what we learned while we were testing some AI solutions in our Federal Qualified Health Center, and kind of put together what we learned and how what we did to address those areas. If we go to the next one, please. Thank you. So I am Sonia Tucker, and I'm the Vice President of Population Health. I lead not only the population health initiatives, but I also lead the risk management team, which is very appropriate for what we are doing here because there is a lot of risk questions related to AI utilization, patient access, experience. And I was a co-PI for this RCT. It was an investigation that we did, but this was in the initial project we had to other AI solutions that we have used in our organization. Edgar, you want to go ahead and introduce yourself?
Yeah, so I'm Edgar Diaz. I'm the Director of Research and Health Promotion at San Ysidro Health. My background is mainly academic, and I've been working for the organization for about 5 years, and I'm one of the co-investigators in the DRESPOCAI study.
Thank you so much, Edgar. If we go to the next one, please. Okay, so first of all, and it's very appropriate that we had this right here. We are a Federal Qualified Health Center. I don't know if you guys know where San Diego County is, but we are in San Diego County, California. And we are really in the south part of the county. That's where we started. However, we're now covering the whole San Diego County, which is a pretty big county. As a Federal Qualified Health Center, we provide an array of services such as medical, dental, behavioral health, and other specialty care services. We serve about 160,000 unique lives. Most of our patients are underserved, and they're also not only in the urban areas, but also in the rural areas of San Diego County. We have been around for a little bit over 55 years. We started as a tiny little casita. And in fact, in the background of this picture, we see a doctor that has already passed, but she was the person that helped write the grant for us to be a Federal Qualified Health Center, Dr. Cobell. She's in the background of that particular picture. DRESPOCAI is what we're going to be using as an example of AI and what we learned from the AI, but DRESPOCAI is a diabetic retinopathy screening point of care utilizing AI that we use to try to really transform care for diabetic patients. So it was a transformative and innovative and sustainable solution utilizing artificial intelligence, where we wanted to bring something to address a problem that we found within our patient populations that were diabetic. This particular solution was delivered in the primary care settings, and we were trying to advance access to care for patients in the community. So that is, who we are. We are we cover a vast area in San Diego County. We have quite a few patients. We have about 3,000 employees and 26 clinics around San Diego County. If we go to the next one, please. So we're going to go ahead and start. What was our first lesson? When we started working with contemplating the possibility to applying for a grant, we wanted to say, okay, and I think we all have that urge. It's like, okay, we want to try the next new thing. My recommendation, or our recommendation to you guys, is identify what your problem is and aim the definition. I am a quality person and a population health management person. So from my perspective, if you are thinking about quality of care, or from the quality perspective, you have to define your aim. So always PDSA cycle, think about it. So you define your aim. And from the population health management perspective, identify what your gap is. That is important, because if you don't do that, if you go blind, your solution could potentially fail. So before you implement any AI, clearly define what is your clinical problem. In this case, it's clinical, if you're going to use a clinical solution, but if it's AI, whatever you're using, please define your problem. Define which affected population you're aiming the solution for. What are the barriers that are contributing to that particular problem? So in our case, was low screening rates. There were access limitations. Do we have a workflow issue? So try to define that as much as possible. Ensure that the problem and the solution are measurable, so that way you can see if your AI solution is helping with your problem. One thing that I cannot stress this enough. Please, 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 do not use a technology solution just because it's the novelty of it. It's the new shining toy. That is important because you want to make sure that the technology, the solution, the AI solution works for you and not you for the solution. So let me show you guys how we were able to address this part in our work. So we knew that diabetic retinopathy is a really serious condition. And we could have chosen anything from the different areas that we have, but we needed to see, okay, what makes sense? So we know it's a serious condition, can cause blindness on patients that are diabetic, and we want to make sure that we prevent that. But we also know that having a screening is extremely important. But there were other problems that we needed to address. So we also know that this problem has different stage in progression. So for the clinical staff here, the clinical people, you know that there's two stages. There is mild to moderate diabetic retinopathy and vision-threatening retinopathy. So we wanted to get to those patients before they develop any kind of problem in their eyes. So we define our problem. We have diabetic patients. We have this many diabetic patients. We have a problem, which is those patients are going to go blind if they don't get if they don't get their screening. So the next problem was like, okay, so do we know how many or what's our percentage in compliance rate for this patient? So if we go to the next one, please, we can see not only we have a problem because we have 15,000 diabetic patients, and those patients are all across San Diego County. If we look at our point number 4, only 35% of the San Ysidro Health patients, in fact, were compliant with their diabetic retinopathy. Not only that, majority of our patients are low income, which is another barrier. We look at access to care, and we had a referral system creating access because of the workflow that we had. We also have social drivers of health that we identify as a problem for our patients. And then if we look at the bigger picture, we know that this is a preventable problem that is costing $70 billion annually to the United States healthcare system, because we're not necessarily we can try to provide the screening, but we were not really being effective because of different barriers, whether it's social drivers of health or because there were barriers to the referral process, the education for the patients, low income. There were different barriers that were identified. So not only that, we know, generically statistically talking, there is about 9.6 million people in the United States that are affected by diabetic retinopathy. So we knew we had the problem. So that was the first thing. We knew what were the issues of that problem. So we had our first thing. Okay, we identified that. So now what else? So we needed to think, if we go to the next one. So we needed to think about, okay, so now we need a solution, right? So we had our problem. So now we need a solution. Our solution was going to be an AI point of care for diabetic retinopathy screening. We knew that there was an immediate impact that we could potentially have on that end by getting accurate results. We could potentially re-stratify the results in minutes, and we were trying to transform the care of those particular patients. So if we go to the next one, please. So we were trying to use AI technology for risk stratification. So we knew we had the big picture. We knew that we had a problem. We knew that there was a solution. We decided to start investigating how many solutions were out there. Did we have to start a solution ourselves? So that's when we realized, okay, there are solutions already available out there. The other part that we did before we implemented or choose our solution is we looked at who was FDA approved or FDA clear. So after those, we realized, okay, so after we look at, we have this many that were FDA approved or FDA clear, knowing what the problem that we had, we needed to choose what was the one that were giving us a better buck for our money, if you will. So there was one solution that was not only FDA clear, but could give us 2 different stages of the diagnosis for this particular problem. And that's when we chose not only that, that we needed AI, but that were FDA clear and also will give us more diagnosis if we were implementing. So that's when we chose our solution. And we're going to, a little bit later, we're going to talk about which solutions we chose, but we had a vetting process because we had in the past not had a vetting process, and we went with the first option that we had, and it had backfired, not necessarily for clinical AI, but for other AI solutions. So we decided to have a vetting process, 3 different vendors, and we had a characteristic, and we developed a scorecard that was used to choose the vendor that we chose. So part of the solution, that part of what we were looking at was the risk stratification. So was the patient positive? Was the patient ungradable or negative? Are we able to get those 3 different characteristics for the solution that we were looking at? And we were able to do that. So if the patient was positive, we had a stat referral. If the patient was ungradable, we needed an urgent referral. If the patient was negative, so we were asking the patient to come back 12 months later. So we had to design with the solution, at least what we wanted the outcome to be. We go to the next one, please. So that's when the lessons number 2 and number 3 came. So first we thought, okay, we had, especially as the operations / research team, well, we got it all. We know exactly what we're doing. So, but then we said, wait, let's stop, because we had done this before where we didn't necessarily include all the stakeholders and we didn't necessarily have the multidisciplinary team. So we kind of stopped ourselves, even though we had already tried to start working with that. And we took a step back and said, okay, now we need to look at, do we have a multidisciplinary team that can address the different areas that need to be part of that? Which initially we started IT and us as the research team, a research and quality team. And that's when we realized that, wait a second, we don't only need IT, research, and quality. We need the experts, so the clinical team, the internal medicine / family practice providers, the optometrists, that we have the opportunity to have an optometry within our staff. Not only we have the IT team, but also the interface team, the research team, the quality team, and the risk department team also were part of the multidisciplinary team. So from the risk management, from the quality perspective, we have to think about build or use the process improvement that you have in place. If you have one, great. If you don't have, build one. From the population health management perspective, we have to look about system integration. How do we integrate the solution within the system that we have? To be able to really have an effective AI implementation, we require a collaboration across multiple disciplines. We have clinical teams, we had IT teams, we had operations team, quality, population health, risk, compliance were part of all these conversations. That way we ensure that the integration of the solution was seamless. We're looking at the different, not only, we didn't want to necessarily change the workflow, but we want to make sure that everything was in very aligning with what we had already. So very important is that your solution comes to be part of your workflow. You don't want it to reinvent a workflow, because you won't know if that solution eventually is going to work, or if changing the workflow was what worked for your problem. something that I cannot stress enough is please, 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 please. And that's something that we started doing it without it. And then we kind of took a step back and said, okay, we need to bring your providers should be your partners. And especially if you're using AI in the clinical setting, should be your partners in the solution, because you want buy-in from the providers. The providers, you have to make sure that they have a say in what you're doing. So what we did is we had a group of providers that were our champions, and we met with them more than what I think they cared to meet with us, but it was a positive, very positive experience. We took everything into account of what they wanted. They knew their workflow. So, and also not only the providers, but other clinical teams. So if you have RNs, MAs, clinical staff that, case managers that are part of this, it's important that you take them into account. AI solution must have, if it's going to be used for a clinical support decision tool, you have to make sure that it enhances the provider decision making and not replacing. I think that's something that we have to keep in mind, because you cannot take the human out of the loop. It is important that we have the human in the loop, because just like anything, this could potentially, fail, or keep in mind that, some AI solutions could hallucinate. We want to make sure that you have a person in there. So on the bottom of this particular slide, you are going to see who our partners are. So the solution that we used for this, for this problem was iNuke through iArt. We also partner with UCSD and San Ysidro Health to be part of this particular work. So I want to show you guys how we did it in San Ysidro with this work. If we go to the next one, please. So what we decided to do is, this is the solution that the hardware solution that we chose. After we had done the vetting process, we had chose iNuke as part as our solution, as our partner, as well as UCSD. So we needed to get the hardware. So it wasn't San Ysidro, the one that said, or Sonia that said, this is what we're going to get. So we met with our clinical staff. We make sure that we took into account what they prefer. So part of our diabetic retinopathy screening equipment was the choice of the experts that were working. So we use a Topcon camera 400 that was integrated, or that interface with the algorithm that was provided to us by iNuke, and we were able to implement that into our interfaces within our EMR. If we go to the next one, we're also going to see what we did. And this is not Sonia or Edgar's solution. So what we decided to do, with the help of our clinicians as well as our operations team, was interface this whole process within our EMR. So we established an HL7 interface, so that way the workflow was seamless. So, and that's something that I said before, we want to make sure that we didn't necessarily put this into a different isolated area, but that was here to help the provider provider decision-making was enhanced. So via the HL7 interface, we were able to put it within our EMR. Our EMR is Epic, and we designed a workflow. So the patient it says admission by register. When the patient was registered, there was an order that was placed into our EMR, and that order went down to the iArt server. The iArt server will get that order into the work list that was taken by one of our staff, and the staff will take the pictures with the camera that you guys saw before. The results go to the cloud, or the images will go to the cloud. The cloud or that solution will give us a result that will come back to the patient's chart for the provider to review. So the results were 4 different possibilities. So mild to moderate diabetic retinopathy, vision-threatening retinopathy, ungradable, or negative, mainly normal. Then what we did with the help of the providers as well as the clinical staff is we stratify a referral trigger so that when the provider signed into the patient's chart, the results were there and they will say, okay, so do you agree with the results? What do you want to do now? Do you want to send a referral? We are telling you that according to the results that we see right there, we propose that you send this patient to a higher level of care because there is a possibility of a vision-threatening retinopathy or mild to moderate retinopathy. So the provider could potentially agree or dismiss depending on what the provider needed to do. So I wanted to show you guys, we didn't make the decision. The AI solution didn't make the decision for the provider. It's just help the provider to make the decision. This is what we are proposing to you. Ultimately, it's the provider's decision. If it was ungradable, it was also, we needed to make sure there might be something else in there. We want to make sure that this patient gets to a higher level of care. Do you agree or disagree? Do you want to send the patient to optometry or ophthalmology? The provider had the option to choose what they wanted to do, but that was all designed with their input. And it took a multidisciplinary team to get to this particular part. And the same thing if it was negative, because if the solution came to us and say is negative, there is nothing, but the patient had maybe some symptoms, the provider could override that and send the patient to a higher level of care anyways. So there was part, even though we automate everything, we use AI for that, we wanted to make the whole workflow more seamless and more automatic. We decided not to take the provider away or from the workflow because it's ultimately their decision. We just wanted to help them. So that is how we were able to overcome those lessons. And it sounded easier, but we made a little bit of mistake, and then we came back and kind of make sure that we were able to address those. And there are other lessons that Edgar is going to take from here and share with you guys.
Thank you, Sonia. If we go to the next one, I think you have heard from Sonia everything that we did prior to any kind of implementation, no? And it comes to the next lesson, no? Like you have to do pilot testing, you have to prove concepts, and we have to start small. Like for instance, a clinic like San Ysidro, as you see, we have 26 locations, 20 different clinics, no? That probably all of them have different populations, different settings, different ways that we need to apply things, and different set of providers. So I think going into having a small implementation and trying to learn from that and trying to see if things are working as you were expecting, if the systems are behaving as we were expecting, or there are issues that we can identify in the workflows that we were planning and in the outcomes that we are getting. No, for us that was an important piece, and we did some different tests. We did tests with employees. We invite some of the providers, and then we invite some of the patients, just to try to learn about the point of view from the patient, the point of view from the provider, the point of view from the administrator, because all of them are important. And also it teaches about like what happened with the data, like what are the questions, like what are the worries from the provider, what are the worries from the patients, and how we can apply these to improve the process, to act from the risk mitigation perspective in what is important for each one of the parts, and how we can be compliant in every sense. And if we go to the next one, for us, because we have also a hypothesis about the use of these, and we were doing a research project, of course, was an internal research phase. No? So this became something different because we have inclusion, exclusion criteria, and we were enrolling patients, we were inviting them. There was a lot of data collection, and it provided a nice window into the implementation, into the effects, into the advantages of this very specific solution that we were investigating, but also thought about some of the information that we can use once we transition this into clinical practice. We have completed recruitment from our clinical trial. We are doing just a final analysis right now and getting some of the final follow-up data. And we have started our quality improvement phase. For a lot of clinics, for a lot of places, this is actually the first phase, no? You have the systems, you put everything, and you start doing your quality improvement phases. And this is like, okay, what happened? Everything that we did for research is a little bit different, but now that we're gonna do the implementation from a perspective of operations, what needs to be different, no? And that's part of what we're doing, no? Can we build for this? Actually, like all the vendors will tell you, oh yes, we have this CPT code that you can use and you can bill for that. Is that true? Or my contracts? No, like we are a federally qualified health centers. A lot of our rates are capitated. So we found this insurance say, oh yeah, of course, it's covered, but it's covered under capitation. So is any way to get some return for the investment and be able to make this investment self-sustainable, no? And that's part of what we're working, and there's other ways that we can have to get some return from these investments, and that's what we call the sustainability phase. No, can we talk to the healthcare providers? Can they give us some kind of incentives, or can we just like the outcome-based incentives? So can we improve reimbursement rates because we are providing some of these services? So I guess this becomes something that is specific to each one of the clinics, each one of the locations, and to the type of billing systems that they have. But it's important, no, because everything that we do needs to be sustainable. And if we go to the next ones, just very briefly, just as I say, because the way we choose to do this, it was a research study, and we were trying to evaluate the implementation, the effectiveness of the multi components. For us, it was not only the screening. We have a health education component. We were doing some follow-ups with the patients. We were offering patient navigation. So it was just trying to understand the impact of each one of those components. And we have inclusion and exclusion criteria that it was mainly based about the solution that we have chosen. No, it was only to be used for adults that in FDA terminology is 22 years of age or older, and they have to be patients San Ysidro, and the exclusions that we have were patients that won't benefit from a screening, but not beyond that. And we decided to implement in 3 of our clinics. And this was a decision for one of the clinics that don't have the optometrist. We have an optometrist in one of our larger clinics, but not in all of them. So most of these patients needed to have external referrals to the provider. So these are the ones that probably would benefit more from this kind of intervention. So that's how we selected our clinics. We selected different populations. We were serving one in the South Bend, like the southwest area of San Diego, one more in the central region, and one more very close to downtown. And if we go to the next one, this goes to the next topic. Is not only getting the solution, getting the feedback from the providers. We also need to get during the implementation phase and during the process, stakeholder and end user feedback. No, prior to the implementation, we did a pre-mortem process. No, like something that we do in research. We call groups, we invite people, and we ask them, okay, this is the implementation that we did. Tell me why it failed. So the idea was to get that information of trying to identify all the things that people will see as possible failures. We took all this information and we took it into consideration, and we tried to react to that preemptively. And if we go to the next one, you have some of that information. We conducted 7 different focus groups. What we call a co-design phase. This is something that we do in most of our projects. We know how important it is to involve, as Sonia was saying, the patients, the providers, the clinical administrators, everybody who's would have different touch points in any kind of these solutions. So just to try to have the different perspectives and see how, like, they see problems that probably we don't see from our perspective as research or as implementators of a different program. And we learned a lot of things. A lot of them we were not expecting. A lot of them were useful for the future. So 73% of the patient or staff solutions that they were recommended in this phase of co-design were implemented in the research phase. And 19% of them were flagged for future adoption during the operation phase, is what we're doing right now. Different approaches. Some things were adequate to research, others not. So we just take, but a lot of that information, when you see, was useful. No, so most of the information that came from people was useful. Something that we were worried, something that it was identified in the initial focus group, is that people probably won't have as much, they were reluctant to accept the use of technology, and they will be worried about the use of what will happen to the data, what will happen to their information, and there might be some hesitation from patients to use the technology. And we found out that this was more a worry from the administrators, from the providers, from others, than for the actual patients. Something that it was pleasantly surprising for us was that patients were really engaged with using new technologies. They were very happy to have new technologies available to them. And we've been surveying our patients, and 92% of those patients that have been part of the program will recommend the use of the AI for diabetic retinopathy screening for friends and family. That is the best way to see how somebody will like. If you recommend it to your mother, to your father, to your daughter, it means that you trust what's happening. Actually, 60% of them say, "Oh, I want to repeat the same time of screening next year." And something about the results is that the machine is not perfect. Sometimes we have ungradable results. So this is not effective for everybody, And even patients that have an ungradable result, they say, I like to try it, or I would recommend it for somebody. So they saw the value on these. And 20% of the patients say, I can do either one. So they have no preference between using AI or going to an optometrist and ophthalmologist. So we see that the vast majority, 80%, were happy to continue using the technology, And only 14% say that they prefer to go to an optometrist for the next time. And that's something that we were trying to see, Do people really need that human touch? Or do real people say, okay, this was good for one time, but next time I just want to make sure that somebody come and see me and I want to have that interaction with a human. When we asked people to describe the technology and see how they feel, and we gave them a choice of words, half of them were positive, half of them were negative. The vast majority, I would say vast majority is incredible high numbers, have used very positive terms. Convenient, 69%, secure, 37%, accurate, 54%. Only a small amount, 1 to 2%, use terms that were it was confusing, it was impersonal, it was invasive. And this is just examples. There were many different choices there. Something very important, all these numbers are preliminary and published data. We're still doing the final data analysis, so these numbers might be subject to change. But when we look at this, I think that the biggest thing, and even that is in the middle of the episode for the end, you heard Sonia saying 35% of our patients are compliant with the screening. 82% of those patients that were part of the AI group completed the screening and within 90 days. And when I say 82%, why is not 100%? Because the machine is not perfect. We have a number of patients that are ungradable, and some of them are referred to a higher level of care also. And we're also tracking within 90 days how many of those complete those referrals. So at this time, we have 82%, 80%, 18% of those were ungradable and they did not complete the screening within those 90 days. And 40% of the patients that were in the control group, that they just got the referrals and they got the health education and they have the patient navigation, completed the screening within 90 days. Something that we noticed, most of the patients that are going to complete the screening, they do it within 90 days of the referral. There is a small number of patients that go 7% more that complete that between 90 and 180 days. And when we're talking that this is a yearly screening, if you complete it 6 months later or more than 6 months later, is actually too far, And there is a small number of patients that complete after 180 days. So this could be due to more touch points. Something to note, as you see, there is even an increase in those that were in the usual care group. And it's a significant increase. And we think that this is because all the awareness that was about the screenings in the clinics, like we were doing referrals, we were doing health education, people knew, the providers were aware, everybody knew about the study. So this makes that the providers talk with the patients see the information. So there was a natural increase of some of these numbers in the clinic just because of that highlighted information and the components. And if we go to the next one, we are also using that data, to be able to, like all these patients, everything that we're getting, we are using that data to be able to track um, um, the information and see how we can use it, no? So can we then, because patients are interested in this health education component in this preventative part, can we then originate, for instance, as in a PDSA cycle, can we try preventive primary care visits where we invite some of these patients to come for this AI screening for diabetic retinopathy, but they also have a food screening or they have an A1C taken. So we can do several different screenings related to diabetes at the same time, and then we can probably generate some of this revenue. And that's something that we're looking into in the same way that, as I mentioned before, some of the incentives. And if we go to the next one, it goes to, for instance, what I was telling you right now, even with the heightened information and the awareness, we saw that even the control group have an increase over what it was the baseline in the clinic. So this is kind of things that you need to keep in mind. No, it's not only the intervention, it's not only what you are doing. You have to make sure that you have stability in the infrastructure during the evaluation phase. So if you start changing too many things, it will be difficult to see what the change is, what is really creating the change. No, is the solution, or is because you modify the system, you modify the workflows, you modify everything. So just take an approach that allow you to isolate these different variables that you have, and be able to measure what you really want to measure. Um, Starting small also help in that sense, the other lesson that we were talking, because then probably you can do different implementations in different clinics in similar settings, and just trying to test the difference between one approach and the other to see which one is more effective, or if it's the combination of both. And if we go to the next one, that's kind of the approach that we took. We basically we knew our population, we knew the clinics that are having issues or that have very lower rates and the ones that have higher. This is just a map of San Diego County, and this is the clinics that San Ysidro has. And you see there is a big difference. No, we have a lot of clinics in urban settings. That is what you see in the lower left corner, but we also have several rural clinics and the suburbs. So these are clinics like if you see on the right in the bottom, Campo is the only thing 40 miles around, is the only service provider. So there are different settings, different things that you can evaluate, and different approaches. No, so for us, it was okay. First, of course, going into the higher volume clinics, being able to provide these services so we can serve many more patients. But what happened to those patients that are further away? And when you think this could be the ones that benefit more from these kind of technologies, no? And having access to the AI and having access to these the immediateness of these results without having to move themselves or transport themselves for 45, 40 or 50 miles to get an appointment to a doctor. So that's what we decided to test, the idea of using some of our mobile clinics. So can we just bring the service to them, create a schedule, and being able to provide some of these clinics that they don't have enough volume of patients to support the cost of one of these machines. Maybe we can just have it on wheels and be able to go and do some of these screenings. So that's some of the ideas that we are testing, and they allow us to move into the best approach that could have equity to the different patients and reach all of our communities. And Sonia, you want to go back to?
Yes, if we go to the next one, please. I know in the interest of time, I want to, kind of close us up with a few other, considerations during implementation. Make sure that you have data readiness in your infrastructure. And the reason why I say that is because we implemented this technology, or this solution started this journey in the midst of changing EMRs, which was it put a little bit of layer of complexity for our work. So which we were able, thankfully, to have our data. But if your data is not ready, just make sure that you have, because you want to make sure that you measure impact. the other part is when you're looking at your solution, your AI models, make sure that your AI models are trained in your diverse population that is representative of the databases the data sets that you're working with. It's extremely important to that, because the AI, keep in mind that the AI solutions will give you information depending on what they're trained on. Granted, the good thing is you can keep training those solutions. So that's an area that we also learned with utilizing it. Thankfully, we had a great relationship and partnership with with iArt and iNook, so we could make sure that the information that we were feeding into the algorithm was giving us the correct results. If you want buy-in, train. It is extremely important, no matter what they tell you that is a plug and play. AI solutions or AI is something that you need to not only train the AI, but also train your staff. Because the more you train into the tools and the more transparency you have, the better buy-in you're going to have. Very important, you have to cost your solution, cost and funding. Make sure that you have that clear. Establish partnerships. Look for grants if you have grants. It is important that you look and that you focus on areas that can improve efficiency and that it can improve patients' outcome without putting your patients at risk. Not because it's the new shining toy, you don't need to implement that. You need to always have this patient center and provider center. Helping your providers provide better care and really looking at efficiency is the way that we should go when it comes down to AI. Very important, solution must be HIPAA compliant. So always bring your HIPAA person. Work with Duke University has great resources on making sure that the solution that you're choosing is HIPAA compliant. Because the last thing you want is implement this great tool and all of a sudden have a HIPAA violation. And ensure that there is transparency in the solution in the workflow and the solutions that you're using. How does that AI work? Even if you're not an IT person, have the minimal understanding of how the AI is going to work. Next one, please. Now, there is opportunities for using AI. So very important. There is 4 opportunities that we have identified on AI solution. Clinical decision support. It really is, keep in mind that I'm not saying clinical decision making. It is supporting your provider to make the decision and risk stratification of your patients. Operational efficiencies. We have other solutions that we are testing utilizing AI that is all about getting more efficiency in operation. Population health management. That's the last 2, of course, I put it right there because that's what I live in. So population health management and predictive analytics. Those are areas that are pretty safe. Nonetheless, don't take your analytics people out of the equation either. You should assess your readiness. Start small, always with a proof of concept, something small, because if it doesn't work, you want to be able to pivot. Engage patients and provider, and make sure that you're able to measure your impact. Edgar?
Yeah, and just to close, we go to the next slide. I think that the most important part, and I think we've been focused on this, the reason for this, and the most important part to keep in mind is what is the reason that you're doing. I don't know what is the aim goal. And for us, it's part of that societal impact that we can have in our patients. So we want to improve lives. We want to improve the life and the access of our patients. And for us, the SPOCA is more than that. Those efficient workflows, all the shiny tools, all this information that we're giving you is about preventing blindness and enhancing lives in the communities we serve, because that's what we are. We do research, but we are a healthcare providing organization, and we do everything to bring the services to our patients. And we know that this is the most common condition that create blindness, but it's also preventable. So when we're thinking about doing early diagnosis, early treatment, and all this information, we are helping the patients maintain their vision. That it means maintaining independence and being able to have more fulfilling lives. So for us, that is the impact, and the impact is what you can do in the life of the patients. Thank you. We're open for questions.
Thank you both so much. We will go ahead and open the floor for questions. I'm going to start with one or two that were in the chat, and then if we have time, if there are others that are added to the chat, or if you want to raise your hand, I will get to those as well if we can. First, do you know what the cost-benefit ratio was between these two methods, AI versus the traditional screening route?
I think we don't have a exact number, but something that when we put it this way with AI, you're doing the screening on real time. You're identifying patients that are negative and don't need to be referred to a higher level of care. With the patients that are positive, we are sending them to not necessarily to an optometrist to get a testing, but to a retina specialist to have treatment. So you are removing one step in that process for most of the patients. So you are liberating resources for optometrists and ophthalmologists to see patients that need access in a different way, and also you are reducing the time of the patients. The cost of the equipment exists. Is not something that it will break the bank. No, I don't want to say any numbers because probably the numbers that we have is different to the numbers that others might get, because it depends of the use and the deal that they make. But is something that is not prohibitive. But it still is significant for some organizations. And I think is having the ability to do the integration in the systems and all that, everything adds up, But the benefits, and we have seen with the number of screenings how it has improved, and also with the satisfaction of the patients and the providers with the screening.
Absolutely. From a value-based care perspective, there's a huge add-on, it seems. Another question from the chat. I think Michael had a clarifying question of what was, the average turnaround time between the referral out and then the return of the results of the screening when patients were sent to see an ophthalmologist or an optometrist.
So I want to kind of get clarification. I was trying to answer the questions here. So utilizing the technology that we have right here, it takes seconds, 10 to 30 seconds to get the results. Now, sending the patient outside of our system for a follow-up, if that is the question. So it depends on, but keep in mind that we're in San Diego County, so we're pretty vast, the areas where we are. So if we're talking about rural, the access in the rural area is a little bit more limited than if we're in urban. And also we need to take into account patients' social drivers of health, transportation, understanding, and education, which Edgar was saying. We with the work we did, we empowered the patients to understand why it was needed. So before the implementation, it would take more than 6 months before the patient would go see the ophthalmology, if they did. During the implementation of this particular solution, once we sent the patient out, because the patient, if there was a mild to moderate or vision-threatening retinopathy, the referral was sent stat. We saw patients that were seen within a week.
And
Edgar?
So yeah, just thinking from the data that we have in the clinical trial, and this is different to like everything that it was happening in the organization without all this additional support. When I was trying to make that difference, when I was talking between less than 90 days and more than 90 days, 90 days is kind of that threshold that we think between you send a referral, we want the patient to complete the referral within 90 days. We see patients in usual care, 40% of those patients completed within 3 months, most of them between 1 and 3 months. Then after 90 days, there is about a 7% more patients that complete between 90 and 180 days. And the rest of the patients don't complete the referral. So that gives you an idea of the timeline of people going and getting the screening. And of course, also that screening has to come back to us. That is not always the case, depending on where they go. So when you compare that to like having the result right away in the clinic without an appointment, but somebody that's just walking out of the appointment with the PCP, being able to do the screening and having immediate results and have the referral if needed to a higher level of care, the significance is right there.
Absolutely. I'll take one last question from the chat. If there are other questions that we don't get to, feel free to reach out and we can email them over to the presenters. But in the interest of time, how long did it take to implement the whole process?
And I say we're still in the process, no? If you're thinking about like from when we started to when we went operational in the research phase, it took us between 6 and 7 months, no? But keep in mind, we were doing also IRBs, other things, but at the same time, while we're doing all this research part, we were working on the integration of systems and in the different components and making all these focus groups and everything. So everything happened in tandem, no? But I would say that we haven't completed that process because we are still making adjustments and we're still making things. So it's kind of continuous. I don't know, Sonia, how you feel about that.
It's a continue, but I'm assuming that the question is more to like, okay, if I wanted to implement this, how long would it take me? So I think the one that takes a little bit longer is the interface with the EMR and designing the workflow, because the solution already, we purchased the solution. So I would say, for the implementation of the HL7 interface and making sure that the interface and the workflow that you're designing is in fact working as intended, the initial phase should be about 3 months. That's more or less what we see when it comes down to integrating two systems and then testing. But this never stops because you always look at, okay, so maybe we need to tweak the workflow this way, PDSA cycles again. So because we were in an RCT with a research component, so it took us a little bit longer, and we're still in the midst of that. So now we are transferring these two operations. We've had a few already testing sessions where you don't have all you don't need all these whistles and bells that we need to have with the research, but in general, I would say 3 months for the interface, and then you have to give yourself at least 3 months to tweak, 3 more months to tweak any areas that are not necessarily working as intended.
I think you make a great point about implementing any AI tool just being always an iterative process of learning and adjusting and making small tweaks. But thank you both so much for your presentation today. We really enjoyed having you and hearing those lessons learned. I think you did a really great job of sharing how you how you address challenges as they came up. So thank you both so much, and I will hand it back to us.
Great. Thank you, Sierra. And thank you, Dr. Diaz and Sonia and the team at San Ysidro Health. Let me just quickly add myself here to the spotlight. Wonderful. Just the last minute announcements here as we wrap up. Thank you again for all for taking the time to join today, and for those who've continued to join our monthly AI in Action webinars. You'll see, probably not to scroll up too much, the link to share your feedback. It should only take a few moments. We'd really appreciate hearing it. It really does work to help shape our subsequent AI in Action convenings. Drop in chat if something comes or has emerged as top of mind, is something you'd like to see covered in our sessions. The team with Health AI Partnership, CCI, and our partners that we said earlier will review that and hopefully bring that up in an upcoming call. We do have a February session coming up. We're still confirming those details, so you'll hear and find out more information on, of course, to register from us at CCI or from Health AI Partnership. So stay tuned for that. Other than that, this is where we leave you with about 2 minutes to spare. Again, San Ysidro Health, thank you for your lessons. You'll get folks in the call and those who registered not here today will get the recap, some takeaways, the slides, and the recording available to you. So we hope to see you in our next AI in Action session. Thank you all for joining.
Thank you.